2013-2014 year. We had a social last month, which we hope many of you joined us for. But we're kicking off our educational and social series tonight. And I'm Craig Schneider, Senior Health Researcher at Mathematica Policy Research and Program Chair for New England Himss. So on behalf of the whole board, welcome this evening. And I'm delighted to introduce our speaker tonight. In thinking about how we wanted to kick off the series, right? Everyone's talking about the Affordable Care Act and accountable care and payment reform. So we wanted to latch on to that theme and be very focused as well on health information technology. So it was sort of a natural topic to seek out a speaker on what are the health information technology needs of an accountable care organization. And then I thought, well, we could pick partners and, have a tremendous admiration and respect for partners. But when you say, oh, well, partners did this, everyone says, well, they're partners. Like, it's not like I could do that. So we wanted an ambulatory accountable care organization because you can look at an ambulatory care organization and kind of imagine that I could do that, we could do that. So we're actually blessed in the Boston area. You may not be aware of this. We have the greatest concentration of Medicare pioneer accountable care organizations in the country. 5 of the 23 are in Greater Boston. And 2 are ambulatory care folk. Well, I guess 3. How do you count Beth Israel?
They're a combo.
Okay, they're a combo. So 2. Mount Auburn, Cambridge, IPA, and Atrius Health. So we're absolutely delighted to have Dr. Michael Lee, who's the medical officer for clinical informatics, close enough, for Atrius Health, to talk about how he and his colleagues are strategizing developing health IT in an ACO. So please join me in welcoming Dr. Lee.
I've got some help with my slides here. I'm not used to the slide thing, so I'll key you when it's time to go. So hopefully we'll have lots of time for questions and chat afterward. I try not to talk too long, and I've got Judy Rems here from our organization who's here to keep me in check and make sure I don't lie about what we did or what we're doing. So I'm happy to be here. Why don't we give it a whirl and see how it goes? Go ahead and go ahead. So Atrius, just so you know, we're going to buzz through these quickly. We are a nonprofit alliance of 6 medical groups and then a VNA care network that joined this year. So we are 6 large multi-specialty groups that all function independently with a parent that is Atrius Health. We're all on a single electronic record platform, except for Reliant Medical Group, which has their own instance of Epic. So the rest I operate and coordinate the larger Epic for the rest of us, and then Reliant has their own, and then VNA Care Network is on their own software plans. They just joined Atrius. So those are all the Atrius sites. If you didn't know, partners may be big, but we're actually taking over the world. Those blue dots right there, those are all the Atrius Health clinical sites right there. And I work right at that one. I'm a pediatrician, and I still practice as well as do this in my spare time. You can go ahead. So we have about...
Speak close to the mic.
Oh, I thought you wanted me away from the mic because it was giving feedback.
Somewhere in between.
Somewhere in between, okay. So we have about 1 million, we have about 1 million patients overall, and that encompasses through the entire network. About 1,000 physicians, many other allied health practitioners. And so we're all on the EMR. We have a large patient portal, which I think Judy told me the other day, just over half now of Harvard Vanguard patients are actually on the portal. I think network-wide we're at about 45% of our patients using the patient portal, which is one of the highest in the country, actually. We have a very long history with global payments. So Harvard Community Health Plan is now Harvard Vanguard, one of the original staff model HMOs. But all the groups dealt with global and capitated payments in the early HMO years and then transitioned back to fee-for-service and are now in the larger ACO and pay-for-performance world. So we're a pioneer ACO. As you know, there were 2 different programs that came up, the Medicare Shared Savings and Pioneer. as Craig mentioned, and we're one of the 5 pioneer groups. Of the original 32, I think it was 9 dropped out in the first year of the ACO world, not being able to either support or figure out how to get this to work. And we have an infrastructure, including financial reporting and data analysis, to manage risk, meaning that we sort of feel that we have the understanding, at least, how to manage a population based on a performance and cost mechanics that we had in place before deciding to be a Pioneer ACO. And I think that helped us with some of the analysis. But as you'll see, some of the projects are still pretty tricky. So go ahead. So the way this works, just so people understand, since you may or may not understand the structure, the big difference between being an ACO is the government, CMS, Center for Medicare Services, deciding to share their claim information with the providers of care. So in the past, when you had, say Harvard Pilgrim Healthcare, and you had a capitated population, the insurer was sharing that information with the medical groups that were managing the patient population. Okay? But the government has never shared any payment information with providers before. So the idea being, if you're a Medicare patient coming to see us, all that business is fee-for-service, and it remains fee-for-service, but the government had all the information, so you never really knew what happened to patients who were outside of your network. And that's one of the big changes in Pioneer ACOs, is the government finally saying, if the patient agrees, we will share all the claims information. So if you see a patient at Atrius Health and we assign them to you as a primary care organization, then anywhere they go, we will let you know those claims that come through. So those patients don't always need referrals, and they don't need other things. They can go to emergency rooms, they can live in Florida, they can travel around the country, and they can use their Medicare, but we have no idea what's going on with their care outside of our organization. So now we would if we got involved in this program. Okay. Just want to make sure. So the concept, right, is to take all those patients and take a payment structure for them and say, can you really save money and improve care for this group of patients? That's really the goal of this entire experiment. And it is an experiment. It's coming out of the CMMI piece, of the government, and the Center for Medicare and Medicaid Innovation. So this is an experiment that they're trying to do nationally with these groups of people who can handle this kind of population of patients and see if they can actually demonstrate what the care is for these patients and that we can provide value. You can go ahead. So how big is this population? It doesn't seem very big, actually. I was amazed how small it is overall. So Atrius has about 1 million patients. 25,000 of them are in our Pioneer ACO. So it's a very small number overall. And then if you look at Medicare Advantage is a patient signs up almost to a Medicare HMO. And so Tufts Tufts Medicare Preferred has a Medicare product that they offer, and patients sign up for that. And it turns out we take care of about 25,000 of those patients as well. So we have 25,000 in the Pioneer, 25,000 in Tufts Medicare Preferred. All of those are managed to some degree against a contract for expense and quality. So there's really two separate populations, but they're in a similar vein with each other. Okay? And so the idea is that there's very challenging requirements for both. So Tufts Medicare has very significant criteria that you have to demonstrate to be able to say that you're going to take care of all of the areas for this patient's care. And the government has their own set of criteria, and they don't match. You'd like to think that they would match. It's all Medicare, right? But they don't match, and it really creates a lot of work for our teams. Even just the very beginning, figuring out which patients you own is one of the most challenging pieces of this whole thing. So the government assigns them based on the frequency of visits and some other criteria that they use to assign them to your organization. But they may not, in fact, be yours. They may have seen a cardiologist 3 times, but really have a primary care physician somewhere else. Okay? So you have to then go through and validate that those patients are in fact yours. And because we are 6 different medical practices, everyone has to go back and say, which one of these do I own? What if it's a patient who sees doctors at Harvard Vanguard and Deta Medical where I practice? Which one of those groups actually owns that patient as we go for reporting and follow-up? Who actually owns these patients? That took a fair bit of work to do that piece and to try and figure out what that is. The other piece is that the patient has to consent to be involved. So if the patient says, I'm not sharing my data, we're still responsible for them as the pioneer. We just don't get the data. So it's bass backwards, if you want to put it that way. It's kind of crazy. We have agreed to take care of these patients with or without the data, but the overwhelming majority went ahead and consented to do that. But a patient could say, I'm not sharing any of my claims information with you, yet we're still responsible for their financial performance. It's a nutty kind of contract.
You said overwhelming majority. What kind of overwhelming majority?
I think it's in the 99% range. I don't know the exact number, but it's a very small number of patients who elect not to data share. And why do you think that is? Because they can't understand the question. Right? It's not mean to the patients. This stuff is so complicated that patients just come in and sign, and what do you think I should do, doc? I think you should do it, and they sign it, right?
Or they don't want their pre-existing condition to be noted in the system.
Yeah, or maybe they don't want something else noted, but there are a very small percentage of patients. The same will come up with health information exchange, where there's going to be this whole consent process. And if it takes me 3 years sitting on meetings with the state health information exchange to understand the rules, how are we going to explain that in 41 seconds at registration of the patient, right? So the patients are going to sign, because that's what they do with all that stuff. They sign the insurance thing, and they sign the contract, and they do whatever seems right, and they don't really get all the information. But the truth is, it's not a harmful thing for them. At least we don't think so. We think it's in their best interest. But I think, unfortunately, it's less that they know. So you have to do a rigorous patient identification, and then we had to figure out how we're going to represent that in Epic, which is our electronic patient record. And Epic didn't really have a really good answer for this out of the gate. And then they said, well, why don't you try this way, try that way. We ended up essentially creating an insurance product that we called Pioneer. So essentially, we assigned them to that based on this thing, and we created a product, and that's how we identified in our system. As it ends up, Epic came up with, I think, 3 different recommendations and different pioneers. I think there are 9 Epic clients that are pioneers. So of those, people are doing slightly different variations on that theme. But that's basically how we decided to do it. And then one of the big questions that came up was whether or not we should actually tell providers when they're caring for these patients that they're ACO patients or not. And we elected essentially not to do that. You can find their insurance classifications, if you go and hunt for it. But in general, when we take care of patients, and we do this across the board, when we enter into a contract that we think supports patient care, we actually deliver it across all patients, regardless of what the contract is. So that's how we decided to do this. So if we were going to do falls risk assessments on elderly patients, then we're going to do them on all of our elderly patients, even though it's only the Pioneer ACO that's counting whether or not we do falls risk assessments. And that's really a clinical approach that we've taken to deal with that. Go ahead. So that was task 1, kind of figuring out what we had to do and get involved in this thing. And this was an extraordinarily complex contract. I think in the end result, if you look at it, you think you're a little nuts for signing up for it, to be honest with you. What is really the piece here? We already felt we were doing this kind of work for a long time, getting into this and flipping our organization around just to do this work. But I really feel that our CEO and executives felt very strongly that this represented the work that we were trying to do. So how could we not get into this? And that's really was the organizational approach. But it wasn't without some trepidation, because there was a fair bit of risk here, and trying to figure it out was not easy. So one of the things you needed to do out of the gate was you have to figure out how to report on all the quality measures to CMS. So you can't get anywhere with them if you can't report the quality measures. So the quality measures are across a wide range of clinical performance indicators, not all of which we were supporting at that time. So some of them, you have to really find a way of producing those assessments and evaluations of patients on a regular basis in a standardized way with standard work throughout the organization, which, as Judy will attest, we are guaranteed to provide standard work at all times in our organization. Is that you get fired if you don't do standard work at Atrius Health. No, so we're, as you know, there's 6 clinical organizations, right? Every doctor wants to be like every other doctor, right? They never see themselves as unique, and they don't think that their care of patients is unique in any way. So they're happy to do things exactly as we tell them to do. So we figured that there were probably about 9 ways that they were assessing for depression, and 11 ways that doing other stuff. We weren't doing other stuff around falls. There was a whole bunch of information that we need to gather around heart failure and other kinds of quality measures that are really, really challenging for us. And I think 5 of them in the end are still manual chart review. So you think that we are this incredibly highly performing analytic and EMR organization, and 5 of those 33 measures we have to do by manual chart review. We had to pay people to come in and look at the records. And I think that shows kind of maybe how as regulatory bodies think about things and put things into legislation and regulation, they're really not always in touch with what's going on in the real world, right? We see that with meaningful use, we see it with health information exchange, we see it with this type of work, that trying to get the government to see really where the technology is at is extraordinarily challenging, and I think we'll see it. Yes?
Did you comment on any of that regulation?
So we are very good with commentary, and I actually didn't comment on any of this legislation, although I'm a vigorous commenter on meaningful use legislation. But we actually participate a lot in the notice of proposed rulemaking and stuff like that. But these regulations, they're thousands of pages long. The meaningful use ones, if you've read them, are 1,200 pages each stage. So to try to read through them, get to them all, take notes, produce some kind of coherent document and return back in the time that it requires to get these things, it's a challenge, but as I was saying to Craig and I were sitting there just before the talk, this area of government has been extraordinarily participatory, meaning that it's really not a closed door over there. They actually will pick up, they'll answer the phone if we call them on the phone. They came to visit a few weeks ago, and they all come and sit down in a room and listen to what we're doing and try to figure out what's working, what's not working. It's been a really, really good experience from that level. It doesn't mean that legislation isn't a pain in the neck or that regulations aren't a bigger pain in the neck and all that kind of stuff, and you wish that you hadn't contracted for things that you had contracted for. But I have to say that in this area, this has been a very cooperative arrangement. Will it be successful? We'll see, but that's where it's been. So these are our quality reporting. This bottom line, I was also joking about a little bit earlier. So they have all these quality measures, but nobody really knows what the benchmark is for a community or for actual reporting. Like, what should the number be? If you're really taking care of your patients well, what's the 90th percentile? Who would be the top of performing? So CMS didn't know, so for a lot of the measures, they just put 90%. We think if you want to be in the 90th percentile, you should achieve a 90% on this measure, even though the actual 90th percentile might be 15%. We learned that with diabetes composite measures, that if you took your diabetic population and you said, okay, what percentage of them have their sugar in control, their blood pressure in control, and their lipids in control? The 95th percentile, I think, in the United States is 15. 15% of the patients have all of them in control. Atrius right now is at 47. Okay, so those kind of measures, but we've dealt with that Blue Cross alternative quality contract for 5 years. For 5 years we've been working on those measures and reporting them back and going to clinicians, right? But it's certainly not 90. So if they had set 90 as the threshold for something like that, we'd fail miserably, right? And they don't really know where these thresholds are. So go on. Terrible with asking you to change slides. You're doing a very good job. So, what happened on the IT side? And I figure, you guys are a bunch of IT nerds. You'll figure this out, okay? The first line is, in fact, really true. So, one of the problems you run into in all organizations is the time lag between when they think they want you to do something, when they agree to have you do something, and when you can implement something. And in IT, that's one area where that is essentially a truth all the way through. That the build of a project, just the project build itself, and then testing, and then delivery, is a fairly long period of time. For most of our major projects, that's a 9-month timeline. And Judy knows after years of working together that our timelines generally for major projects run about 9 months from beginning to end, from when we decide what our work effort's going to be all the way through that cycle. Okay? For this project, we had no internal resources available for this project. And we told them at the beginning, when we went to sign, that we needed resources if they wanted to build. It really took our executive team 6 months to commit resources, to commit dollars for us to buy the resources. And part of the reason we told them we needed to hire right away is that for us to onboard somebody takes about 3 months. And then for us to train them to use our system and understand our protocols and our security and our development takes about 3 months. So even after we decide to hire them, it could be a 6-month lag before they're ready to build. And I don't know where you guys are in your organizations, but those things are significant. And for a project like this, we were blessed. We got 2 great analysts but that took us that period of time to get them. So 6-month lag before they said we could hire them, and then 6 months to get them in, and then about a month after they were in the door, they're like, well, where's everything? And we said, well, you remember that meeting we had about the time lag between the thing? Well, that's what we were talking about. So, we ramped up very, very quickly from there, but it took a long time to get these tools out. This was not a short process. So we identified this at the beginning of end of 2011, right? And so this process of onboarding and training, we didn't deliver our first tools till March of 2013, our first major tools. So it was about 15 or 16 months after the project was identified. And that's a long time for your executive team that thinks they have this cool contract with CMS and they want to see financial performance changes in 2013, right? And we can't even deliver the tools until March. So that caused a bit of organizational ruffling. So the initial spec was around 50 projects. 50 projects in all were identified that we had to do. We obviously did not have that capacity to deliver 50 in a very short period of time. So we went through, we have a very friendly but cooperative and sometimes antagonistic prioritization process where we go in and wrestle through what the priorities are. For this particular project, we took about a dozen people from the care teams, as well as the IT leadership, myself, some other people, and sat down at a table and just banged through all these and said, what do we need? What do we need to report? So that was basically to hit this contract, we had to do something. Those had to be the highest. Then what are our highest clinical priorities? Where do you see the greatest need? Some of that was documentation tools. Some of that was the other things. Coordination tools, hospital infrastructure, so getting information in from the hospitals, things like that. So we took about 15 projects in stage 1 that were primarily assessments and reporting, and then starting to build on where we thought the care mechanisms would go in the following year, and that's how we went through that. Go ahead. I think that we had a really good pairing of our Epic team and then our operational teams that really had to do this in terms of making this stuff work. They built training time, they built time to deliver these tools. They're trying to figure out how to get clinicians and care teams to do this work in a standardized way and use all the tools that we deliver. So they have to test them, they have to do the business analysis, do all that kind of stuff, and we're just responsible for the build. I think on some of the areas, I bring up falls assessment and depression screening as our most dramatic, where we had so many ways of doing these things, and within, I think I have a slide here. The next slide? Oh no, that's okay. You can see it that way. So in falls risk, I think 50% of the patients had been screened for falls risk and depression screening in the first 4 months of operation of the project. So that means all of those patients, since we're only reporting on the standardized tools, all those patients are screened doing our standardized tools. And not only that, then they built in feedback into it to say, if your patient fails a falls risk assessment, what do you do with that patient? They automated a referral to physical therapy to help them with that. It automated, a recommendation for behavioral health screening. So if they fail a depression screening, if they're mild, you might do this. If they're moderate, you might start them on medication and refer them to psychology. If they're, so it gave recommendations throughout that, and very, very helpful. And advanced care planning was another piece. Really starting to think about end-of-life issues and talking to patients about that was another big part of our work. You can go ahead. So this would give you an example. I don't think there's anything secret in there, Judy. Just strike it. Stand in front of the screen. There's anything secret in there. So this is an example of 20 different registries that a patient might be entered into. So this is basically a scoring sheet, of all the things, identification of the patient, risk score trending, current risk, DXCG, which is a software platform that we bought to help do predictive modeling based on patients' behavior and claims that were identified. Congestive heart failure, chronic obstructive pulmonary disease, all of these are different kind of registries that a patient might be assigned to help us figure out what was going on with them. You can go to the next one. These were examples of areas where we were failing. So this was at the beginning of the year, so the end of 2012. Here's the CMS threshold, and these were areas where we were failing. This was falls, I think this was falls, yeah. This was falls risk. And as I said, this was a full calendar year in 2012 of using non-standardized tools. And in 2013, in 4 months, between March and July, we were already just about at this level. So we're really on a trend to try to break the percentages that we need. You can go ahead. These are just examples, of things that we were looking at the beginning of this process. So this was depression screening. Again, as I said, we were over 50%. in 4 months. Go ahead. This was tobacco use. And why do you think we were at 99.5% for tobacco use? Anybody have any idea?
Stage 1.
Stage 1 meaningful use, right? It required it. So here's an example where you're getting some crossover of value there. So stage 1 meaningful use, everyone had to hit that button. Didn't matter whether you asked the question or not, whether they were really smoking, but you had to hit that button. This was congestive heart failure. This is actually impressive to me. This was actually before the start of the ACO work. This is the patients who are diagnosed with a low ejection fraction who are already on beta blockers. It was 100% at Atrius Health before the start of the program. I was so impressed with that metric. You know, that's really our cardiology department doing that. So this is an example of gating, and this isn't ACO, but this is alternative quality contract. And what I wanted to do is give you an idea of what the history of where this started from in measurement. So this starts in 2009, which is the dark blue here. And every year in our quality contract, our gates go higher to reach the kind of performance that we were looked at for in that contract. So this was our experience in this work. And what you can see is every year the colors go up, so that we're actually achieving. These are performance outcome quality measures. These are not just assessment quality measures. This doesn't mean you just check somebody's cholesterol. This means you actually reduce their cholesterol. Okay, these are performance outcome measures. We're improving on the gates every year. And then once the ACO work started, all of a sudden you can see that purple line even jumping higher. So that the quality measures that we were already working on are actually accelerated by this work in ACO. So we're seeing ourselves trending toward gates that we didn't anticipate because the work is starting to synergize from one program to another. Go ahead. Here's the slide I was looking for earlier. So I knew I had it in here somewhere. So that was the falls risk and the PHQ up top. The dramatic acceleration in 4 months of use of those tools. And I think that's really that's where you're seeing the value of the business and the IT working together, because the business people figured out a way to get the practice to use the tools that we were building, and the tools were usable enough that people didn't object too strenuously to using them, right? It's a balance between all those things. You go ahead. So what do we need to do now, okay? So now this is where it gets challenging. So now we get all these tools in place, we can report. Now what we really want to do is improve the care and reduce the total medical expense while improving the patient experience. That's the triple aim. You're trying to do those 3 things simultaneously, okay? So we have things that we've put in are a real-time hospital database. So now when our patients are hitting our connected hospitals, we're getting immediate feeds from those hospitals right into our EMR that those events have taken place. So you hit the emergency room, you're admitted to a hospital, you're discharged from a hospital. Those messages are coming automatically into Epic. They're being managed by a report of case managers who are seeing patients who are hitting the hospital, so that there's a follow-up set up for those patients who have been to the ER, so they don't go back to the ER. Things like that. There was a great program on cellulitis at the Beth Israel Hospital, where they were getting 25 admissions a quarter for cellulitis, which is an infection of your skin, and they reduced that to 14 a quarter over about a 6-month period of time, just by doing this kind of work and making follow-up in our urgent care sites immediately after the ER visit, rather than having the patients be admitted. So dramatic reductions over a short period of time. Care plans is a very coordinated effort to get a kind of unified care plan for patients across the spectrum of care. So it's basically a shared document that all of the care team can use with a number of discrete pieces to it. This is something we built in conjunction with Epic. They actually took their most recent version of software and then built stuff backwards for us into our version so that we could support this effort. And then they're using us as their kind of demonstration model to build this out for other groups. So it's a very exciting piece of work that our team's been involved with. Go ahead. And then, as I mentioned earlier, Tufts Medicare Advantage is another population of patients with similar problems. The tools don't line up perfectly, and now we're doing some catch up on their tools to make sure that we can deliver everything that they need in Tufts Medicare Preferred as well. So they need some different documentation and reporting tools. And what we really need now is a bit of a pause. So actually Epic is calling me almost every other week saying, okay, we really need to hear from you what your next things are that you need. And the honest answer is we don't know exactly what we need yet. The tools haven't been in place long enough that we have enough feedback to know exactly what to tell them to build next. So it's actually a funny plan. We were bugging the heck out of them to get going fast. They got us what we needed to get out of the gate, and now we're a little unclear as to exactly what direction we need to go in with them, and for other in our next set of build. So we have our prioritization list, so we know what we're building internally, but we're not exactly sure which area we need to take the software to move next. So where are we? This is my last slide, I think, and then I'd love to take questions. So when CMS followed up, my understanding was their reports were that our quality measures were sensational, was one of the words that they used with us. So that our quality reports as an organization are really at the top level even of the pioneers. And we're very, very excited to be in that place. But part of the deal was we have to also reduce expense. And the way the contract works is you have a risk band, okay, around what they expect your expense to be. And the idea is you have to reduce that more than 2%, and then based on your quality scores, if you save more than that 2%, then you get most of it if your quality scores are really high, and you get very little of that savings if your quality scores are really low. And that was the incentive to try to prevent you from reducing services unnecessarily. Okay, so if we could have saved 10%, then we would have gotten 8% of that savings as a payment to us. So that would have been a supplemental payment to us from Medicare for our services, and that would have been a great boon. Where we landed was right in the risk band. So if you're within that 2%, they call you noise, meaning that there may be errors in the claims, whatever. 2% is all forgive, all forget. So basically we made no money, they made no money. That was our first year of performance. The good part is that we have seen quarter over quarter for 4 straight quarters a reduction in total medical expense, both in the ACO product and in the Tufts Medicare Preferred product. So actually both of our products are showing reduction of expense 4 consecutive quarters. So that's a really good sign for us moving into next year's piece of the contract, but we're still not yielding any money despite all the effort that we put into it. So we call that the halo effect in our Medicare Advantage product. And we have seen the accelerated quality performance, but we're not making money on this product yet. So great quality scores, no extra money made. One of the tricks that we ran into is our baseline cost is around $10,500, I think, dollars per patient. And the average benchmark cost at CMS is about $1,000 more than that a year. So we're already 10% under their average network cost. So to think that we can then reduce that by another 10% and really make money on this, that may be a bit of a stretch. And unfortunately, we didn't really know all those numbers out of the gate. So when we signed the contract, we didn't really have a good identification of that. But that's asking a lot to say that we're gonna decrease more than that. Questions? There we go. Hope that wasn't too long. And that's our performance on the ACO. And I'd love to take your questions if you have any. Yes.
Great presentation.
Thank you.
Question, when you started to try to come up with standard care plans, when you worked with all the different various medical groups and different physicians within those groups, how did you tackle that?
So the care plans, as in the patient care plans, or any of the work that we did? I'll repeat. Yeah, I'm just going to try. Which one? The patient care plan, their consolidated care plan, or any piece of the work that we were doing?
Actually both, if you don't mind.
So the question was, how did we come up with a standardized process and work around this? It's a really good question, and not so. Some of the things like assessments, you really have limited options. So Epic probably has about 5 different options for which you can do the same kind of a thing. And so our goal was really to try to find the easiest function and the clearest function to look at for people that would enable us to count it and then to score it and then to provide recommendations back. And I think those types of assessments were probably the easiest. Judy might agree. The depression and the falls risk and those kind of things, there were several others. We put a checklist in, like a green, yellow, red checklist, so people could see whether stuff was done or not. So very simple to use, really no training once you did them. You did them once, that was it. There wasn't any real training, so I think we were lucky in that some of the software tools available to us now were not available, say, 3 years ago. So we had the advantage of a little better user interface. Epic sometimes has some clunky user interfaces historically, and they're getting better at that. So then it's really up to people like Judy Rems and her team to deliver those products out. So we have a training team. They do analysis with people. They show them to clinicians. We have design groups of clinicians who look at these things. We have a very broad design work group that I run every week, where there's a fairly large number of people on the call, and we bring the tools there and say, what do you guys think? And clinicians, operations people, Epic people, non-Epic people listen in on those calls. So we get a fair bit of feedback back from those, and then the second piece is who's going to do the work. And obviously we're trying to deliver some of this work to the non-physicians, right? So that an MA rooming the patient can use these tools as part of standard work. And but it takes some drive and communication. I honestly, maybe Judy can answer. I don't know how you make everybody do it that way. I think if you make it easier, it's more likely to happen that way. Our care managers, when we're talking about the care plan, they were dealing with a 15-page, I think, form that had multiple variables in it that took them over an hour to complete. The new form that's been developed for them it takes them just about 1 hour less per form to complete. So I think if you make the software match the need, it's not so hard to get people to convert. I think that there are many times, I'm sure with all EMRs, not just Epic, where the software is not intuitive, and therefore we cannot get people to do things, in a standard way. I hope that answers your question. Yes?
So looking at the results from year one and also what the other pioneer ACOs have done, some obviously did save a lot of money.
Yeah.
What are you thinking about changing in going forward for Atrius in the high-end program?
So I was going to fire Judy because she's our highest paid employee, and I figured that no. So I really think I think that this was a year for us in getting the foundational tools in, and I don't think anyone was really surprised or upset with the results, to be honest with you. I think that some of my friends at Partners, as an example, were amazed that we even signed the contract when it came out, because there was so little information available from CMS in terms of what our exact financial performance was, that this was really a bit of a shot in the dark. I think from a business perspective, you could have argued that this was nuts to even sign up for when it first came out. But I think from a care perspective, it was the right thing to do, because we felt it's the right thing overall to do, not only for our patients but for other people's patients. So we felt very aligned with it. I think for us, really, the drivers are they're a challenge. So you have a network where the cost of services varies very greatly within the city. Okay, so I can tell you that one hospital system that we refer to, an average hospital day is about $5,000 a day more than another hospital system that we refer to. That's a huge amount of money when you talk about the volume of patients who go through these systems. At the same time, we have areas of Atrius that really cannot refer out of the network that they're built into, because patients are used to going to those hospitals. They're local hospitals for them. Even if they may be part of tertiary networks, they're still local hospitals to those patients. So telling them they're going to go from the South Shore to Leahy Clinic is not going to work, right? It's just the math on that, driving 80 miles as an elderly couple to go have your heart failure appointment, it's not going to work, right? And so we're going to have to figure out a way to use our network locally as best as we possibly can. And probably be a little blinded to who owns those networks, but work more aggressively on understanding what the cost and performance of those networks is. As an ambulatory-only network, we are really a victim of our local hospitals.
As are we as patients.
There you go. No, I say that's true. I used to joke, I don't know if you know Tom Lee, but he used to be the head of Peachy. He's now the CMO of Preskini, and he's a good friend. And I used to say that people go to your hospital to die. They come to me to stay alive. So you got to fix that dynamic there. But the hospitals do a lot of really unnecessary, really expensive things. And the more that we can convince them to get out of that culture, the better off we'll all be. As part of that, they do great work. That's world-leading work. It's just unbelievable. But they also do a lot of things that are incredibly wasteful and expensive. And in some areas, they just charge too darn much. And my bigger worry is that as our insurance premiums level in this state, they've been leveling, which is very good for Massachusetts overall. The hospitals are still the tougher nut and still grab the higher percentage of those premium dollars, and that'll affect groups like Atrius Health a lot. those margin dollars are the same for everyone's running at 1 to 2% margins. But I like to say our 1 to 2% is skinnier than their 1 to 2%. Yes?
So on the question of care plans, which is an area where there's a lot of work going on right now in terms of standardizing and looking forward to the next round of activity in Meaningful Use Stage 3. How much involvement are your folks, maybe Judy, in looking at some of the standards work that's being done, say, in the LCC activities, in the S&I framework at the national level through ONC, and bringing what you've already learned back to them to say, this was what we developed for a care plan, so to help inform those next stages. Does I see that as being where things are headed?
Yeah, and I think that we have been really involved in that process, and I hope continue to be. I did go testify to ONC this fall around some of our health exchange work. Our view portals, as an example, which you may or may not be aware of, we have the ability to match a patient and look into the electronic records of most of our referring hospitals right now, 11 different hospitals, systems on many different electronic patient records. I can click a button within Epic. If my patient has been seen at the Beth Israel, it will bring me up a web view read-only of the Beth Israel's medical record for that patient. In the context of the exam room, while I'm there, it's real time, all that. We do that with 11 different hospitals, and now 6 hospitals can do that with my EMR. So Children's Hospital and BI and Partners Hospitals, they can click a button on their side and bring up a view-only access. That's something I brought to ONC to show them that not everything's about exchange. You don't always have to send something across a network and receive it and file it. You can actually just look at it and accomplish 99% of what you need to do. I think that those are areas that we're talking to them. I think the care plan issue is one that we're bringing forward as to what our needs are, what our documentation needs are. So one of the areas that's a challenge always in care plans is if you don't document discreetly, you can't report. But documenting discreetly is really a challenge from a time perspective. If you made every physician document every visit in discrete data points, they would kill you eventually, because there's a lot of stuff that just doesn't fit in discrete little bundles, especially when you're talking about historical information. Especially when you're talking about what patients' needs are. But we have a whole section on patient goals, and there are medical goals that we send up, and then there are what we call, what the lingo is the social determinants of health. Kind of the other pieces of the patient's healthcare environment. Maybe it's a cost piece, maybe it's a housing piece, maybe it's a transportation piece, maybe it's a family support piece. What are the patient's goals? Their goal maybe, I just want to go to, my grandson's bar mitzvah in 3 months. That's their goal. Their goal isn't, I want my blood pressure lower. That's not commonly coming from patients. And how to blend those two and also display them in a way so that if you're the cardiologist, you want to see the blood pressure goal. You may want to see on the side the goal about the bar mitzvah so you understand what's going on with that patient, but that's probably not the first one that you're looking at. But if you're the care manager who's working with that patient, you need to see all of them, and you need to figure out which ones are the most important for the patient at that moment. Yes?
Have you had any success with unstructured or free text data mining tools to sort of look for tags and tease out data that way? So
we haven't played with any of them yet. There's one built into Epic in the 2014 version, which is one version away from where we're going right now, but which is the Nuance tool for natural language processing. So it's coming into real life. I haven't been I'm a big believer in the concept, but I haven't been a big believer that anything I've seen yet in terms of using a natural language tool to piece out truly sensible, identifiable, discrete data that somebody doesn't have to look at and say, yes, this is correct. I haven't seen that yet. But I think they're getting there in certain areas like radiology and some of the defined specialties where you can get specific terminology to mean something, where it's harder to get physicians to describe things in the same way so that a language processor can pull it out and really be correct. But it's really, really cool work. So the people, I think there's no question that's in the future somewhere. I'm just not sure when it's going to hit in real life. Yes?
What advice do you give to other organizations embarking on the ACO journey, like the top tips, and then especially the physicians that are having a difficult time understanding and embarking on this journey, because you have a physician perspective as well?
Yeah, I mean, I think from an organizational perspective, I would only say be prepared. That this is a lot of foundational work that needs to be resourced and assigned. You know, I think IT, as all of you guys know, it lives in the no ROI bucket, right? It's very hard to define a clinical informatics project that has a true ROI. You can come up with some on the billing side. You can come up with Medicare, HCC, coding alternatives so you can get better coding and get better reimbursement. But it's not very easy to come up with a specific project that has an ROI. So when you have something like this, you have to have an executive team that believes what its resourcing structure is so it can do it properly both on the operational level and the IT level. I don't think, this is one of these ones that you cannot do without the IT work. So, and then the second piece is the time. One of the words that I used actually at the CEO Council at Epic when I was speaking to the Epic CEOs, it was around, the Epic client CEOs, was around the word patience. Patience with a CE, not a TS. That a project like this takes time to evolve, and you can't expect immediate turnaround in something like this. So, you know, I think that's one, when you're doing annual reviews, I think as a patient and as a public, they want to see Obamacare in a year, save money, enroll 37 million uninsured Americans, right, and never have them hit the ER again, right? That's not going to happen in a year. It's obviously not going to happen in a month if the whole thing doesn't work. So they make it 5 patients who don't go into the thing. But you know, I think that there needs to be some patience for this stuff to evolve, and people are very short on patience generally in the world that way. I think from the physician level, that's a more of an organizational culture thing. One of my concerns about ACO generally is it's so complicated for these pioneers to get this to work. I can't see how it's going to spread to community organizations that don't have the kind of institutional culture that we have. And I think we're lucky to have it, but it's very difficult if you gave me 35 of the BI deaconesses' small practices and said, Mike, I want you to show the exact same results in those 35 practices that are 4 and 5 doc practices that are affiliated. That's a harder haul. You know, how do you get that communication? How do you make that structure that they believe in this? It takes a long time to do that. Yeah, way in the back. Is that Meg?
You mentioned that you bumped up Gibbs hospital costs.
Yes.
How do you see the whole ACO thing being able to reduce hospital costs? Having the influence eventually to lower costs, reduce unnecessary procedures.
Right. So I think that's a really good point. So hospital charges are one of the areas where you can clearly reduce. So we can use our market power, right, to try to force a hospital to reduce rates. Okay, that's one way to do that. It's really a pathetic way to do it in a way, and it's only going to work for 1 year. Okay, it's never going to give you a long-term sustained reduction in cost. It's going to give you a one-time boom that says, look what we did, we saved costs. But really the only way to do it is to get them engaged in a partnership where they actually believe that they can survive and we can survive with fewer admissions and processes that help. You know, I do believe that our work with the BI has shown that to be the case, that they're actually willing to reduce their admissions and reduce their ER visits by partnering with us on disease conditions around those kind of things. I don't know if everybody's willing to do that. I mean, that's what we'll see. But I do think we have to push. I think we have to push harder with partners as an organization to be able to get that kind of commitment across their network. You hear about it, but when you hear about it and then what gets operationalized are 2 totally different things. So I do think it's a challenge for all of us. But that's really what it takes. And honestly, for our organization, and you know, when I talk to our leadership, I talk to them about reducing visits. Everyone wants to increase visits, right? No CEO wants to see fewer patients coming in the door, okay? But as an ambulatory organization, if we can take care of you at home, if we can put IT tools in that help with video visits, that help with remote monitoring of blood pressure, that you can get your cholesterol drawn at CVS rather than coming to the lab. I mean, there are many ways that we in the community can reduce visits in our own structure. And ambulatory costs are part of the drivers in overall medical costs. If you look at the big difference between us and developed countries, the United States is way above in ambulatory charges as well as hospital and pharmacy charges. It's not just hospital and pharmacy, we can victimize them, but they're not the only source of all the costs.
One more question?
Sure. Anybody else? You want to be last? You get extras.
I've got lots of questions, but one of the ones that comes to mind in terms of the cost drivers and the hospital costs is you actually have access to information. that I as a patient don't, which is what is it going to cost me for that over here or over there or over there? I got an MRI 2 years ago at a facility, it cost me $3,000. 2 years later, it cost me $7,000. It was the same MRI, it was the same radiologist, it was the same building. Everything was the same, a hospital bought it. That was the difference. So is there anything you're looking at doing in terms of making cost transparency information available to patients to let them know? Because that's going to have an impact on them. They're not getting everything paid for by Medicare or Medicaid. Some of that's going to be out of pocket for them. Some piece of that is going to cost them something too.
Yeah, and I think that's a great point. So we've started is the answer. So we are bringing, through SureScripts Payer, we bring the formulary information on medications back into Epic. So I can tell people when things are preferred on their plans or not, so they can reduce medication copays. We're starting to deliver costs of tests, at least by relative costs of tests to people. Because part of the answer is we don't know what the cost is. So if Brigham and Women's is charging $3,000 for an MR, right? But Aetna is only paying them $1,500. HPHC is paying them $1,000. You know, those insurers won't share with us what the actual cost is that's attributable to that patient. We don't have any way of knowing. All we have no way of knowing is what relative charges are. We don't really know the cost to the patient. And I think if the insurers are willing to open up some of that information, that would help the world significantly. But you know, when you try to get this claims data out of CMS, that was a big deal. You try to get claims data out of, you know, or contract data out of Aetna, United, any of the fee-for-service payers, or any of our local insurers that were not at risk for those patients, what they're paying, we don't know. But that's a good example of where the government has shot itself in the foot, right? They give hospitals allowables to charge for a procedure easily delivered in the ambulatory environment. They give them an allowable that's way in excess of the normal cost of that procedure because it's being done in the hospital. It's a completely errant incentive, right? That they're actually incentivizing the hospital to not push this out of their network. It doesn't make any sense. But that's where, see, Craig's talking to these government folks. He can help fix them. But you know, this is where there are holes in these programs that really are a challenge. You know, we're at risk for dollars that we don't decide, and that's you know. So should Atrius just become some massive hospital network, and then we'll have our own dollars? Who knows? You know what the future holds with all that kind of stuff.
Great. Thanks very much.